I would also like to thank C4 and the Cape Cod Symposium on Addictive Disorders for the honor and the privilege of being able to spend part of the morning with you guys today. And not that this is a Grammys acceptance speech or anything like that, or the Oscars, but there are a lot, people do say it does take a village, and it's true. And a lot of very special people helped to make this presentation possible, either by sharing slides with me or by giving me guidance on how to really summarize such an important topic so that I could be here to speak with you guys today. And I'm really, I feel really fortunate that they actually allowed me to speak to you on the last day of the conference, because it allows me to summarize a lot of what you guys may have heard from some fabulous speakers over the past 3 or 4 days. So I really hope to be able to tie in a lot of things that you guys have already heard from other speakers. So I'd like to thank my colleagues from Spring Hill Recovery. Many of them, Eric Eckberg, amongst others, are sitting here in the room. Thank you for being here. Jonathan Horry, who's our medical director. Amanda Wilson, who's a colleague of mine, and Dr. Ruth Poti, who's a Massachusetts physician who does a lot of lecturing statewide on substance use disorders in the brain to high schools and to communities Massachusetts-wide. To my good friend and mentor of many, many years, Dr. John Renner, who's currently in a competing conference in the room next door, go figure. And Melissa Weixner, who's the author of Heroin's Puppet, and It's Not Gonna Be an Addiction, 2 books that she published after the overdose death of her daughter, Amelia Caruso, a few years ago. So as we have to do in all of these presentations, I do have a few disclosures, even though I have not received and currently don't receive any financial support from any pharmaceutical companies. If any of you want to give me your money at the end of the presentation, please see me at the end of the talk, and I'm happy to take your money. The other disclosure, I do work part-time for Blue Cross Blue Shield of Mass, and I am originally from Colombia, which means that I do speak very quickly. So for any of you that do feel like I'm talking too fast, please feel free to do one of these during the presentation and tell me to slow down. So we'll start off with a case or an office presentation, and I've called him Peter. So Peter is a 23-year-old young man with a past history of social anxiety and depression. With hard work and academic support, he graduated college in the middle of his class. He was the first member of his family to attend college. He reports occasional drinking with friends at parties, but denies ever using illicit drugs. His current medication is sertraline, 100 milligrams in the morning. You discuss prescribing his antidepressant medication and encourage him to continue meeting with his individual therapist. He tells you he will be working construction over the summer, doing hands-on work until he finds a more permanent job. You congratulate him on his progress and encourage him to continue to work hard and stay away from drugs. Show of hands, how many of this could be somebody that you may know or that may have been part of your practice? Okay. So let's continue to read and see what happens. Several weeks later, Peter sustains a work-related injury and visits a local emergency department, where he's prescribed oxycodone for pain, 20 milligrams Q4 to 6 hours as needed, and he's given a total of 90 pills. Does this seem familiar too? Okay. He returns to the emergency department 2 weeks later and is given yet another refill for another 90. For the months that follow, his PCP assumes the role of ongoing prescribing. 6 months later, you receive a call from his parents who are worried and report significant changes in their son's behavior. Peter has lost his job, he is unkempt, he has undergone a change in friends, and money has gone missing from the house. Now, does this start to seem familiar too? Okay. So here's the epilogue. Peter starts no-showing to your appointments and those with his therapist. And here I am presenting, in the role of the psychiatrist, but it could be, for any practitioner. Frustrated with his dishonesty and erratic behaviors, his parents ask him to leave the house. 3 weeks later, Peter is found unresponsive in his car with a needle in his arm. First responders administer emergency Narcan to no avail, and Peter is pronounced dead at the scene. And so last night when we were having dinner, several people at the table that are sitting in the audience today asked me, so Sanchez, why is it that you do this type of work if you're not in recovery yourself? And the main reason that I do it is because it's something that's really hit close to home. And I've already lost 2 family members to the impact of substance use disorders and mental health. So, addiction is everywhere. And not only have we lost Andres and John Paul, and when they died, my family came to me asking me, and I was a psychiatrist in the family, right? So they came to me asking me for a lot of questions as to what happened, what could we have done differently? And at the time, not only was I just in residency at Mayo, but I was just the cousin. And I didn't have a lot of the answers. But I thought, you know what, if I can make this my life's worth and understand and make a difference in other people's lives, then maybe I've been able to turn, you know, this experience into something positive. So I do want to dedicate this presentation to Andres, to John Paul, to Amelia, my friend's daughter, and to anybody who's, you know, and lost their lives to the opiate crisis, and to the family members, and to all of you who work with this, you know, this patient in this population. So over the next hour or so, we're going to be talking about, you know, why opioid use disorders is a brain disease. We've had some fabulous speakers over the past few days. You know, Robert Simpson gave a great lecture that I hope many of you attended on addiction and the brain disease. We will go over how we got here and go over the epidemiology and history of the opioid epidemic. And we'll spend some time talking about the role of medication-assisted treatment as an integral part of the treatment of opioid use disorders, and incorporate some of what the research has to say about this, not what the good Dr. Sanchez has to say, and my thoughts and views on it, but certainly bring it back to evidence-based medicine and research. So let's talk a little bit about opioids. Well, as we know, opioids are natural and synthetic substances with morphine-like activity at the mu receptor that have been, and opiates have been used for over 6,000 years for the treatment of headaches, asthma, melancholy, coughing, you know, and pain. In the United States in the Civil Wars, when the introduction of the hypodermic needle really made morphine analgesia standard practice. So the start of morphine for the use of pain, plus a lot of traveling salesmen selling morphine, you know, to housewives that needed a medication to help them cope, were really the first two groups of people that became dependent to opioids, you know, as early as it's 2 centuries ago. Even Bayer Pharmaceuticals, I don't know if any of you guys have seen this ad before, but Bayer Pharmaceuticals, who are the same makers of aspirin, were actually the ones that made heroin. You know, so technically in a CME conference, we probably shouldn't use the word heroin. But what Bayer realized is if they added 2 acetyl groups to salicylic acid and make aspirin, they could add those 2 acetyl groups to morphine and make glycoheroin or heroin. And it became not only the sort of gold standard for helping to treat, you know, coughing attacks and whatnot, but it became the medication that was sort of first started to use as maintenance medication for people that had already started to develop opiate addiction. So continuing prescribing for, you know, heroin as a maintenance medication, so to speak, continued up until 1914, when the Harrison Act prohibited writing prescription opioids to patients for maintenance. And many physicians were actually prosecuted for doing so. And even the American Medical Association eventually came down on the side of the law. So a lot of doctors were put in a very difficult situation where they felt that they were doing the right thing by trying to help their patients with opioid use disorders by using the maintenance model with agonist medications. But again, many were eventually prosecuted, and patients, you know, were left, you know, in withdrawal and on the streets. And so what followed was about 3 or 4 generations of physicians that really had no idea how to treat patients with opioid use disorders. And this became a real problem in the United States. And until 1974, when Dole and Niswander in New York started thinking about, you know, what kept patients addicted to opioids, you know, going. And they realized, well, when you're using heroin every 4 to 6 hours to avoid withdrawal, it makes it pretty difficult to sustain a job. And you're more likely to probably engage in illicit activity if you're having to, you know, leave your job or whatever it is that you're doing to, you know, buy, you know, more heroin to get your next fix. And so they realized, and they thought, well, what would happen if we give patients a long-acting medication that can not only abort withdrawal symptoms, but can also help with cravings, and therefore people can just be on a once-a-day dose in the morning and not go throughout their day with the fluctuations and the ups and downs of using and withdrawing. So this became a great plan, and they instated, and they did so well that eventually the federal government decided to support them in this. But unfortunately, it didn't become part of mainstream medicine. Less than 10% of the people that needed help actually got it at the time. This day and age, fast forward, we have anywhere from 300 to 400,000 people on methadone maintenance. And then comes Data 2000, where we were able to finally bring the treatment of opioid use disorders back into an office-based setting with buprenorphine as a maintenance medication. So moving right along to why, to one of the other reasons why I consider addiction or opioid use disorders a brain disease is that we know that mu receptors are widely distributed in the brain, and that depending on where opioids bind, we get different effects. So we know that if they bind in the thalamus, we get analgesia. Binding in the cortex produces impaired thinking. Binding in the prefrontal cortex contributes to an individual's judgment and impulse inhibition. And of course, conference wouldn't be complete if we didn't talk about the ventral tegmental area and the nucleus accumbens and their role in the limbic system with pleasure and reinforcement and the interplay with the sort of high that we get from dopamine. So as much as we all like to think that our role our role is to get up and go to work every day, our evolutionary goal is really to pass on our genetic material to the next generation. And in doing so, we need dopamine for natural rewards. What are the natural rewards? Sex, good one, right? So food, water, sex, and nurturing, so not necessarily in that order, right? And so in order, for survival of the species to occur, we need dopamine for those things to happen. And dopamine helps to drive two important behaviors, compulsion and perseveration. And so these two behaviors are really good and really important when it comes to survival of the species, because that's what helps us to get up in the mornings and to get going. But apply those two behaviors to the disease of addiction, compulsion and perseveration, and that's where problems really begin to happen, right? And so, so if we use this graph here on trying to understand dopamine levels, if we consider 100 to be a baseline, I think many of us know people that lead their lives sort of half empty and lie at around like an 85 as a basic dopamine level. And we also know those people that are the half glass full people that, for reasons like epigenetics or luck, are at around a 125 at a baseline, right? Well, what happens is when you have a good meal or engage in or have that first ripe June strawberry, that elevates your dopamine levels to 150. Having sex, 200. Real good sex, how much? So I have a shy audience now. Okay. All right, 275, 300. Cocaine, 350. Opiates, depending on which opiate and its potency, maybe anywhere from 500 to 950. Crystal meth, 1250, right? And so what happens to a brain when it's exposed to such high levels of dopamine is that the brain starts to think, wait a second, something's just quite not right, right? We've been on the planet for millions of years and nothing has given me that, that huge dopamine surge. So something must be quite right. And so it really boils down to, the brain starts to think, well, I have, something must be wrong, and it boils down to a small equation that consists of one of three things. Either I'm producing too much dopamine, either there's too many receptors at the end receiving it, or there's not enough, vacuums or dopamine reuptakes inhibitors, to suck up that dopamine from the synaptic cleft. And so what it starts to do to try to bring the brain back to an equilibrium is to reset its basal tone and bring it down. And so what happens to an addicted brain is that, and to somebody that's going through this pattern, is that you find yourself wanting to use even more amounts of the substance, trying to reach that original high, that dopamine high that you felt. And this is an effect that eventually is known as what? Tolerance. This is how tolerance develops in the brain, right? Once you've experienced that, 800, 1250 high, your brain kind of likes it, but it's not sustainable. And so tolerance happens, and you end up using more and more of the drug trying to reach that same effect. But what happens through time is that as that baseline level starts to drop, no longer do you go back to being at the 85 or 100 of a baseline dopamine, but the person that's in the throes of addiction starts to be functioning at a level of maybe 35 or 40, which is why it makes it so difficult for them to get up in the morning and get going and do the things that need to be done. So it's easy to understand why people that have substance use disorders and develop addiction start to appear very depressed and anhedonic through time. People sometimes may ask, is continued drug abuse, a voluntary behavior, or isn't it? Well, maybe the initial decision to use drugs might be voluntary, but we know that with continued use, the person's ability to exert control becomes seriously impaired, and then impaired self-control really becomes the hallmark of addiction. And so many of you have probably seen this slide and may have thought that that we initially would talk about the 3 C's of addiction, which were craving, compulsion, and loss of control. I've expanded it the more that I've done this type of work to really include continued use despite adverse consequences and chronic maladaptive behaviors associated with use, because we do know that part of the hallmark of addiction is that it doesn't fit the phrase of "you would think that," right? That you would think that if you've lost your spouse, you've lost your kids, you've lost your money, you've lost your integrity, you've lost everything, you would think that that would be enough to have you snap out of it or pull yourself up by your bootstraps, like the Minnesotans taught me when I lived in Rochester. But we know that that's not the case, right? And that this is a chronic, relapsing, and remitting condition. And ultimately, in the end, what happens with exposure to addiction is that you feel like your brain breaks and it doesn't function like you want it to because you're held hostage to it. And so knowing what we know about the disruption in the transmission system that happens in the brain, we can say that addiction is a brain disease. Now, I've included this slide here, which, how many of you remember this? Okay. All right, and so good. I'm glad to see that there's a lot of show of hands, because I was afraid that this was going to date me, because I know it was a public service that I back from the 80s, and I know that there's a lot of young people in the audience as well. So this was the public service announcement, that had an initial intention of trying to scare people or scare young people away from using drugs, that this is your brain on drugs, and taking it a step further with this is your brain with a side order of bacon. But the more that I've thought about it, and I think there's unintended consequences to a public service announcement like this one, because I think it unwillingly may give the message that recovery is not possible and that your brain cannot heal. And I often wondered if that something like this didn't actually scare people away from trying to enter recovery and get sober. And I think many of you in this room that have long, solid recoveries are really solid proof that this is possible. So your brain can heal. We all know it takes time, it takes a lot of work in recovery, but it is possible. So I've included the DSM-5 criteria of opioid use disorders. Not to beat a dead horse on how the criteria can really match up the biology, but I've separated the criteria into the white and the yellow section. So the white section represents the behavioral adaptations that someone undergoes when they're in the throes of addiction, right? Using in larger amounts or longer period than intended, trying to cut down and not being able to, spending a lot of time taking a drug, not fulfilling your obligations, giving activities up, continuing use and adverse consequences, that sort of thing, right? Those are the behavioral adaptations of a substance use disorder. But tolerance, withdrawal, and craving are the neurobiologic adaptations, again, that the brain undergoes in addiction. So again, it's interesting how the criteria, for a lot of people that have beef with the DSM, actually really you can tie it in with the brain component. And as many of you know, we no longer use the terminology of abuse and dependence. We talk about substance use disorders, certainly opioid use disorders, and we have a range of severity of mild, moderate, or severe, depending on the number of criteria that are met. Legal consequences has been pulled out, and craving has been put in. So I love this slide because it reminds us that impairment in social and occupational functioning are also the hallmarks and backbone of addiction. But I'll leave you guys to decide if you think that this gentleman has a likelihood of developing a problem with his latte habit. So he says to his doctor, no, I don't take any drugs, but I do have a $50 a day latte habit. Okay, so how did we get here? Well, in many ways, it was a perfect storm. And a show of hands, how many people recognize this slide? Okay. And as William Jacobs said in his presentation, I will go over the next slides pretty quickly for fear of getting a bullet in my head before the end of the presentation. Because it was a perfect storm. And it started off with a VA initiative, hand in hand certainly with JACO throughout the years, on recognizing pain as the fifth vital sign. And so this happened in the 1990s, and we started giving pain equal status with blood pressure, heart rate, respiratory rate, and temperature. And vital signs, as you guys know, are things that we can measure, and pain is something that's very subjective. Yet we were still not only asked, but trained in a lot of CME presentations to ask patients at every visit what their pain level was and to have it rated. And certainly you could get dinged or reprimanded, not only by the hospital, but by accrediting agencies if you didn't do so. And this unfortunately sort of occurred at around the same time that Purdue Pharma released OxyContin in the market, which we all of us know that it was marketed as a safe and non-habit forming opioid for the treatment of pain. And there had been some papers in medical journals, both from the 1980 and 1986, that had suggested to us that less than 1% of people that took their opiates as prescribed for legitimate reasons that were prescribed to them developed an opiate use disorder. And the authors from those two papers from 1980 and 86, granted, they did say that this was an alternative to treating pain and that more research was required. Well, to this day and age, we're still waiting on a lot of that research, but it was all that misunderstanding and misconception of how to treat pain that led to the crisis that we're in now. And and as William Jacobs said in his presentation too, we all drank the Kool-Aid, right? And I remember being at Mayo Clinic and being in CME presentations and being sort of young in my career and wanting to learn how to prescribe medications appropriately, not knowing that we were really only supposed to be prescribing prescription opiates for acute postoperative pain and certainly short term, and for cancer pain. Yet doctors, and you may ask yourself, well, how is it that doctors that vowed, me included, to first do no harm, ended up getting into these prescribing practices? Well, again, we drank the Kool-Aid at the time and ended up prescribing not only opiates for a lot of non-cancer and non-postoperative pain conditions such as fibromyalgia, neuropathic pain, back pain, wisdom teeth removal. But we're the ones that unfortunately created this crisis. And through time, I-95 eventually became known as Oxy Highway, right? And 80 to 90% of the prescriptions that of the opiate supply that arrived to Massachusetts actually came from Florida, and it wasn't prescribed from local doctors, right? But we had people from Ohio and Kentucky getting on buses and going down to Florida, and their only mission was to either go in with a limp to one of the 900 clinics in Florida, or without one, leave with a prescription, give it to your tour guide, and come back. And again, the makers of OxyContin knew this, but eventually they did end up having to, face the law and plead guilty to misbranding. Unfortunately, when they were fined $600 million in fines for the misbranding, this was really just a drop in the bucket because they had made so much money in sales throughout the years that by then, the danger and the harm was done. So the impact of this opioid epidemic can really be summarized in two numbers that I want you to remember, and that's 300 and 500. So 300 is the increase. Since 1999, we had a 300% increase in sales of opioid pain medications in the United States, and 500% has been the mortality increase that has gone in parallel with this. And if you look at this slide from 1999 to 2010, in green you can see the sales of opioids, in yellow the treatment admissions, and again, very parallel to that, the number of deaths that we have seen in this period of time. And really, I cannot think of any condition in medicine that is responsible for such a rapid rate of death increase as the opioid crisis has been. And as you can see, in this slide, again, we lose more people to opiate overdoses than we lose to motor vehicle accidents. So things like, seatbelts that have helped to decrease the rate of motor vehicle accidents, deaths, have gone down. But if we were talking about, if there was information on the news about, 500% increase in deaths related to diabetes, I'm sure we get people's attention, right? Yet it took some time for the stigma to go down, for people to be paying attention to this crisis. And for those of you in the audience that are visual like me, you can see this the problem in picture form, right? This slide, it shows us how from 1991 to 2013, the amount of prescription opioids that were being prescribed in the United States. And this slide is actually, a shocking one to me, where we know that for America, which accounts for 4.6% of the world's population, consumes almost 88% of the world's opiate supply, right? Like there's really something wrong with what we're doing and how we're prescribing, especially when 99% of when Americans consume 99% of the world's Vicodin. We have no other country that's doing this. And in 2012, 259 million prescriptions were written for opioids, which was enough to give every American their own bottle of pills. It's a lot of opiate prescribing. So this slide you guys might be familiar with also, which shows us the source of prescription opioids. Most people get them, 53% get them from a friend or relative. Some friends are not so nice, 10% of them are actually charging you for them. But essentially, they're really easy to get, whether it's from overprescribing from physicians, being able to get it on the street, etc. And this slide shows you, in three different groups. Recent initiates on the left, in the middle, occasional users, and on the right, frequent opiate users. And the blue represents opioids that were obtained by free from a friend or relative without asking. Red is those that were prescribed for one or more doctors. And green, those that were prescribed, bought from a friend, relative, dealer, or the internet. And as you can see, as somebody progresses, through their substance use disorder, through their opioid use disorder, not only are their friends and relatives not giving it to them for free anymore, they're actually having to, buy them from their friends or relatives or from the street. But doctor shopping starts to go up, and people start getting them from more and more doctors, and that's the bar in red. So Massachusetts is not alone in its problems, and I know many of you may have attended the Cape Cod movie the other night. Right, and it's easy to feel as if we are at the epicenter of this crisis. And whenever I lecture nationally, no matter what state I'm in, I'm always hearing people, tell me, well, I'm from Kentucky. This is the state that has the worst opiate problem. Where I'm from, from California, it's worse here. And actually, there's states around the U.S. that actually have it worse than we do. And I actually had to go back and learn my geography, not just for my citizenship exam, but be able to present the states to you guys here today. And states like New Mexico, West Virginia, Nevada, Utah, Alaska have it even worse than we do. So there's a part two, unfortunately, to the perfect storm. I mean, we've spoken a lot about the non-medical use of prescription opioids and how we got here, but unfortunately the story doesn't end here, because as we've pulled the prescription opioids from our patients, be it with well-intended reasons and better prescribing, it's made them switch over to heroin, and that's created dilemmas of its own. So on this slide, you can see, again, the non-medical use of opiate pain relievers in the yellow line on top, and how heroin use, unfortunately, has started to increase as well. You can see, though, however, that the spike in heroin actually started as far back as 2007. So even though the subsequent spike starts to happen around 2012, again, either because of improved prescribing practices or because of tamper-resistant presentations to opiates were put on the market and patients could no longer get their OxyContin and had to switch to heroin as an alternative source. We have had a significant increase, almost a fivefold increase in heroin in the past few years. And in part, the reason behind that is that with increased purity, price has started to go down. And this day and age, it's actually even cheaper to get heroin than a six-pack of beer. And so when I worked at Children's Hospital in Boston, I never imagined in a million years. I mean, if you would ask me even when I was in med school or starting my residency in psychiatry, I never imagined in a million years that I would be working with 15 and 16-year-olds that were already addicted to, to heroin. And part of that, which you've probably heard from other lecturers as well, has to do with brain development. An adolescent brain exposed to prescription opioids, be it for legitimate reasons from a football or soccer or a lacrosse injury, or whether they use them recreationally because they don't think, their prefrontal cortex isn't mature enough to help them to make good decisions for themselves. We were finding, back then that, the kids, and I call them kids because they're younger than I am, but, kids were becoming physiologically and physically dependent on opioids within months or sometimes just even weeks of being prescribed to a prescription opioid or being exposed to them. And kids were going to parties where the parties were called farming parties. Have you guys heard of that? Right, the farming with the pH, where they would throw a lot of pills into a bowl and mixed up with Skittles, and just to see what you could get high on. So again, I never thought that this would be something that I would be seeing. And on the flip side of that, at Children's Hospital, we had a very good, strong, well-run buprenorphine maintenance practice. We were able to help a lot of these adolescents and young adults either not develop careers in their heroin use or not switch from their prescription opioids to heroin by prescribing buprenorphine to them and having their parents hold on to the meds at all times and dispose it appropriately and have supervised dosing, urines, pill counts, etc., along with the psychosocial support. So this is a heroin map now. So you can imagine, Appalachia and the entire South filled in two. And so in this slide, we can see in red the increase in admission, the yellow the increase in overdose rates, in purple the increase in both. And we talk a lot about the overdose rates, but we haven't thought about the number of these patients that are contracting Hep C and HIV from needle sharing, and what this map is going to look like, fast forward in a few years when people start dying from those conditions as well. So there really is no human benefit in pulling back people's prescriptions and having them turn to heroin. So a lot of education it does need to be had. So yeah, Massachusetts, this is a slide from approximately 2 years ago. Massachusetts is in a state of emergency. A quarter of, about a fifth of our budget has gone to substance abuse and substance-related expenses. We've experienced a 950% increase in opioid use disorder development in the past 10 years. And in Massachusetts, we're approximately losing 2 to 3 people a day. If you look at this slide, do you think these are big numbers? If you're a parent, you bet they are. And again, if we had been seeing this rise in cancer deaths or in diabetes deaths, we would certainly have been getting people's attention. So in preparing for this presentation, I wanted to have about as much up-to-date information as I had. This slide is from 2014, so it shows us that up until then, that year, we had almost slightly over 1,000 opioid-related deaths towards the end of 2013, and in just a span of 2 years, it went up to almost 1,400. And I read from a different source last night that actually the final numbers for 2015 was 1,531 opioid overdose deaths. And it's possible that fentanyl, or the emergence of fentanyl on the streets, is responsible for this. And we're not talking about pharmaceutical grade fentanyl. This is underground fentanyl. It's been found to be anywhere from 50 to 100 times stronger than morphine and heroin. And so what unfortunately they're doing is not only are they mixing it with the heroin supplies, but sometimes it's even being crushed to look like a lot of the pills that are on the street. So they're crushed sometimes to make them look like Xanax or like other hydrocodone or oxycodone. So I don't know, show of hands, can anybody really tell the difference between the real one and the fake one that contains fentanyl in them? It's pretty hard. It's pretty hard to do. There's also, I know many of you have heard of carfentanil, which is right, and this is just devastating and new too. This is an elephant tranquilizer that's also started to show up on the street. This one's about 1,000 times stronger. And then there's a substance that was developed by some scientists in Canada several years ago, and that was kept sort of locked up in a laboratory for many years, and it's something called W18, which is 10,000 times stronger than morphine, and samples of that are starting to show up on the streets. So these are really, dangerous times and really important times to be inviting patients in the community to, to enter treatment and to work on their recovery. So in the end, whether I present to you data from the CDC, from NIDA, from ASAM, in the United States, we're losing about 3 people an hour to opiate overdose deaths. So by the time I'm done presenting to you guys to here today, it literally, and pun intended, takes my breath away to think that 6 people will have died in the time that we're here talking about how to be able to find ways of helping them and offer them treatment. So what has our response initially been? Well, in many communities and families, it's been to send people to detox, right? And as I was showing my slides yesterday to the good Dr. Renner, who I shared with you guys, has been my mentor for many years. He's like, Dr. Sanchez, you should not be using the word detox. You should be teaching your audience to really refer to it as opioid withdrawal management. So I edited my slides, and so the correct terminology for us to be using, since Tim Chaney and Mary Woods and John Kelly and others are really big on it's not what you say, it's how you say it. And the importance of the words that we use and the messages that we convey. I will be talking about, in the majority of my slides, about opioid withdrawal management. So again, the response has been to send people inpatient for opioid withdrawal management and to help them get through the uncomfortable symptoms of opioid withdrawal, which we know that even though they're not dangerous or life-threatening, you certainly can't die from opioid withdrawal. You feel like you want to die. And so, patients go, people or patients go inpatient, to receive, medications to help them with the discomfort from the runny nose, the diarrhea, the muscle cramps, the body aches, etc. And it's interesting that phrases that have been used, throughout the years that have to do with opioid withdrawal symptoms, the goose flesh that's experienced, and that we refer to that, and that the phrase of quitting cold turkey we now use for anything from stopping cigarettes abruptly or going on a diet abruptly, cold turkey, and kicking the habit also from the muscle spasms that happen in opioid withdrawal. These are phrases that we use in this day and age for other things. And so oftentimes, again, we prescribe patients comfort meds. I'm not going to go through them individually. We oftentimes prescribe them clonidine, which is an alpha-2 adrenergic agonist, or a medication that's often used in the treatment of high blood pressure. But which is a medication that even though it doesn't do much to help people with cravings, it does help with the sympathetic and autonomic response from withdrawal, the anxiety, the agitation, the sweating. But most importantly, we offer patients agonist medications like methadone or buprenorphine in an inpatient setting, for symptomatic relief. So in this slide that looks at, it compares buprenorphine and clonidine, both in an inpatient and outpatient setting, to see which can do better for detox or for opiate withdrawal management. We see that clonidine really does not do a very good job at helping patients to stay drug-free through time. And so really the only indication why we'd be using clonidine as the sole medication for opioid withdrawal would be if our patient has already told us that they very quickly want to go on Vivitrol as an opioid antagonist. And we don't want to put them on methadone or on buprenorphine and have to wait for that to clear out of their urine before we give them their first Vivitrol injection. But we'll get to that. So bottom line, clonidine is not a very good standalone opioid withdrawal medication. So what is the efficacy of opioid detox or opioid withdrawal treatment? So one of the classic studies was done by Ball, and he looked at tapering patients who had done well on methadone and tapering them off. And unfortunately, what he realized is that 82% of patients relapse within 12 months. Many of them actually relapsing within the first 3 months, right? So as we start to think about the question, does detox work, or should we really be thinking about maintenance? The answer is probably that we should evaluate our patients for the various maintenance options. because detox alone doesn't work. And in his study, we clearly saw that, that patients did relapse. With buprenorphine, Walter Ling from UCLA wanted to look and answer the question, well, is a 7-day taper better than a 28-day taper? Is it, could it be that if we keep patients in an inpatient detox, or if we extend their tapers a little bit longer, that they'll do better? And the answer is no. Patients were still relapsing at very comparable rates, be it 1 month out or 3 months out. There's really no data for ultra-rapid detoxes, which pop up in certain places, either in the U.S. or outside of the country. And these are ultra-rapid detoxes that are done under anesthesia. Again, we don't have a lot of data, certainly not a lot of safety data, and if anything, it might be dangerous. So it's not something that I quickly go to recommend to my patients from an evidence-based standpoint. And at the end, we know that there's a high rate of relapse with all medical withdrawal procedures. And the numbers that we're seeing now is approximately 50% of people that aren't on medication-assisted treatment relapsing within the first 6 months, and up to 90% within the first year. So it's really important to prescribe naloxone rescue kits, as Alex Wally shared with us yesterday. So what actually works in this start by Clark and colleagues that was published just in 2015. The blue and the red lines are buprenorphine and methadone respectively, and the green line are non-opiate agonist treatment behavioral health. So essentially he was comparing buprenorphine and methadone maintenance to behavioral health alone, and the relapse rates are significantly higher with patients that just do treatment alone without the role of medications. So if relapse rates aren't enough, or isn't enough data to convince you, well, what about costs? And so again, if we look at buprenorphine and methadone in the blue and red, and behavioral treatment alone in the green, it's going to cost us more in the long run to just do one or the other. So really, the take-home message is we have to do medication-assisted treatment with psychosocial support to really increase our outcomes and help our patients. But the medication-assisted treatment is really an important and integral part to help that brain to heal, while everything else in our patients' lives, or that person's life, starts falling into place. And again, as Walter Ling said, and I love his quote, detoxification from opioids may be good for a lot of things, but staying off of opioids is not one of them. So how do we treat opioid use disorders effectively? And I think we can all say it together, like a chronic illness, right? With individually tailored treatment. And because again, in the words of Alan Leshner, who was the former director of NIDA, all treatments may work for some, but not one treatment works for all. And different people have different ways of reaching their recovery. And in the end, trying to do things one particular way is the definition of insanity, right? Doing the same thing over and trying and hoping to get different results. So there's, right? So there's a lot of questions that we still have, and that we have, and a lot of answers that we still don't have. I'd like to thank this gentleman for helping us with the fundraising for opioid research. Because, sadly, billions of dollars go to cancer research. And yet again, more people are dying from substance use disorders and their related consequences. And one of the speakers was saying the other day that he's gone to a lot of fundraising, events with millionaires, that are in recovery. And they will still donate more money, to cancer research than to addictions research, because many people, still say, you know what, I entered recovery just with the help of AA or NA. There's no research that needs to be done. I'm giving my money elsewhere. But a lot of questions do need to be answered. So I'm going to pause here and give you guys a break from hearing me speak. And so before we start talking about medication-assisted treatment, I'm going to share a video with you.